Hello, everyone. My name is Dr. Muneera AlKhalifa. I apologize for the inconvenience caused earlier. Today, I'll be talking to you about diabetes and pregnancy, a comparison of guidelines. So our study has been published in Diabetes Updates in January of 2021. So this is what we will be going through. First, we'll start by introducing our topic. Then we will go through the different aspects of managing patients with diabetes and pregnancy. Then we look at the recent updates by current international guidelines. So these are the following abbreviations that we will be referring to during our presentation. So we are differentiating between GDM, which is gestational diabetes mellitus, and pre-existing diabetes. We're also going to refer to several international institutes, such as ACOG, which is American College of Obstetrics and Gynecology, American Diabetes Association, Canadian Diabetes Association, International Federation of Gynecology and Obstetrics, our current institute, which is King Hamad University Hospital, and National Institute for Health and Care Excellence, the Society of Obstetricians and Gynecologists of Canada, and the World Health Organization. So as we are referring to these guidelines, we will be using the letters in parentheses. So we define GDM as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first recognition during pregnancy. It is quite common with a prevalence of 28% worldwide. The risks associated with developing GDM include obesity, older age, higher parity, excessive weight gain in pregnancy, and a previous GDM. Hyperglycemia in pregnancy, whether it is GDM or pre-existing diabetes, they both have a maternal and fetal effects. Such maternal effects include preeclampsia, premature labor, and developing type 2 diabetes postnatally. The fetus might undergo, have or develop congenital anomalies, might have macrosomia or polycythemia. We noticed that the GDM incidence in Bahrain was 5.4% in 1989, and it rose to 12.5% in 2010. The aim of our study was to compare our hospital guidelines of KHOH to international guidelines, such as NICE, WHO, the American and Canadian guidelines, and FIGO. So first of all, for patients with pre-existing diabetes, it's recommended that they undergo preconception counseling. They need to be educated about the risks and the necessary precautions that are required prior to conception. And they need to be managed by a multidisciplinary team that might involve an obstetrician, endocrinologist, or a diabetic educator. We must emphasize the importance of glycemic control prior to conception in order to minimize those risks associated with hyperglycemia. We have to advise those patients to stop teratogenic medications, such as ACE inhibitors and angiotensin receptor blockers. We need to inform them that they need to take folic acid supplementation up to 12 weeks of gestation. They need to undergo retinal assessment before conception, but we need to tell them not to have a very tight glycemic control prior to retinal assessment because it is known to worsen any pre-existing retinopathy. We also need to have their renal assessment. We need to know the degree of kidney function. And they might need to undergo other tests like total serum thyroid function test and ECG. So we can screen for diabetes at booking. They might have pre-existing diabetes, and we can do that using HbA1c or fasting plasma glucose. However, we still need to test them for GDM at 24 to 28 weeks. All guidelines recommend the use of the one-step oral glucose tolerance test. However, the American and Canadian guidelines, they recommend the two-step oral glucose tolerance test as an alternative. Postnatally, we need to screen patients with GDM in case they develop type 2 diabetes mellitus. We do that after 4 or 6 weeks, using the HbA1c or fasted plasma glucose. However, the one-step oral glucose tolerance test is more recommended. NICE and WHO only recommend testing patients with risk factors. They don't recommend screening all patients for GDM. When it comes to diagnostic criteria for diabetes, first we will be comparing the one-step 2-hour oral glucose tolerance test and the two-step oral glucose tolerance test. So first we test the fasting plasma glucose. As you can see, there's a varied list of values. For the fasting plasma glucose, 1 hour, there's a consensus at 10 millimoles per liter or more. And again, we see a difference in the 2-hour plasma glucose levels. So for the one-step 75-gram 2-hour oral glucose tolerance test, we only need one value to diagnose diabetes. Whereas in the two-step oral glucose tolerance test, according to the American and Canadian guidelines, patients need to undergo the 50-gram glucose challenge test first. And if the 1 hour postprandial plasma glucose is 7.8 millimoles or more per liter or more, then they proceed to the next step. According to the American guidelines, the next step is the 100-gram 3-hour oral glucose tolerance test, and the values are as follows. And for the Canadian, according to the Canadian guidelines, they recommend moving on to a two-step to a 75-gram 2-hour oral glucose tolerance test. We also need to note that it is possible to diagnose pre-existing diabetes during pregnancy. And we do that by using HbA1c or fasting plasma glucose. And then postnatally, we can use also HbA1c or fasted plasma glucose to diagnose type 2 diabetes. And the values are if HbA1c is 6.5% or more, or fasting plasma glucose is 7 millimoles per liter or more. But all guidelines, most guidelines also recommend the one-step 75-gram 2-hour oral glucose tolerance test as a test postnatally. And the values are, as you can see in the table. Now we know the diagnostic criteria. Now we need to know, now patients are diagnosed with diabetes. We need to know how often they need to monitor their glucose. So obviously patients with pre-existing diabetes need to monitor their plasma glucose more frequently, and that might include preprandially and bedtime. For GDM, they are required to test their plasma glucose fasting and postprandially. However, NICE recommends them patients with GDM to test their blood glucose levels preprandially and bedtime in case they are on multiple daily insulin injections. When it comes to glycemic targets, preconceptionally, it is recommended to have an HbA1c of less than 6.1% or less than 6.5%. However, if they have bouts of hypoglycemia, we can have a higher target of less than 7%. We can also use fasting plasma glucose to monitor their glycemic target. Antenatally, we use a lower target for HbA1c only because there is a higher red cell turnover during pregnancy. And fasting plasma glucose, our institute has a lower target of less than 5 millimoles per liter. And postprandially, you can also see that 2 hours, NICE has the lower target. We also need to maintain glycemic control intrapartum. We'd like to reduce birth asphyxia maternal and neonatal hypoglycemia. We'd like a target of between 4 to 7 millimoles per liter. In order to maintain such values, we can use IV insulin or dextrose. Antenatally, we need to follow up patients with diabetes more frequently. So as usual, you'd like to confirm viability and gestational age by 7 to 9 weeks. Then they need to undergo an anomaly scan at 18 to 20 weeks. And we also need to monitor fetal growth through ultrasound. And we'd like to do that every 4 weeks during 28 to 36 weeks. And FIGO only mentions the guidelines for patients with GDM, so they recommend screening or monitoring fetal growth every 2 to 4 weeks from diagnosis. We also want to perform fetal well-being tests at 36 or 38 weeks. And when we're administering corticosteroids, we need to adjust the insulin dose over 5 or 7 days. Other tests that might be required include a fetal echocardiography or umbilical artery Doppler. When managing patients with pre-existing diabetes, we'd like to switch from oral hypoglycemic agents to insulin, only because insulin resistance increases during pregnancy and it might be difficult for oral agents to overcome that. We can also use metformin as an adjunct or alternative. Aspirin is administered as prophylaxis against preeclamptic toxemia. When managing patients with gestational diabetes mellitus, we recommend diet and exercise at first. Medical nutrition therapy is also recommended with a goal of 175 grams of carbohydrate per day. When this fails, then we refer to pharmacological therapy. The first line of treatment is insulin. Alternatives include metformin or glyburide, but metformin is preferred to glyburide because it is less associated with hypoglycemia. NICE, however, has a different approach. So if fasting plasma glucose is less than 7 millimoles per liter, then the first line is metformin. But if it is 7 or more, then we start with insulin, and an alternative is glyburide. Induction of labor can help reduce the excess fetal growth, shoulder dystocia, and cesarean section. It is recommended to perform a prophylactic cesarean section if estimated fetal weight is more than 4.5 kilograms. In general, delivering patients with pre-existing diabetes depends on the presence of complications. So in general, if patients have complications, they are recommended to deliver earlier than patients with no complications. And when delivering patients with GDM, it depends on its management. If they are on lifestyle modifications, then they are recommended to deliver at a later date compared to patients on pharmacological therapy. NICE recommends induction of labor or elective cesarean section before 40 plus 6 weeks, regardless of their management. And FIGO also recommends earlier delivery if there's complications such as macrosomia. NICE is the only list of guidelines that gives recommendations on neonatal care. So they recommend delivering in a tertiary healthcare center equipped with an ICU. Feeding is recommended within 30 minutes of delivery and then every 2 to 3 hours after that, with the aim of the plasma glucose of the baby being more than 2 millimoles per liter. We need to test the blood glucose every 2 to 4 hours after birth. If they have hypoglycemia, then we give IV dextrose. We need to test for the complications associated with hyperglycemia, such as polycythemia, hypocalcemia, and hypomagnesemia. We admit to the NICU if the patient demonstrates signs of respiratory distress, jaundice, or hypoglycemia. We can only discharge the baby if they are more than 24 hours old. Postnatally, we recommend that patients with pre-existing diabetes to return to their pre-pregnancy insulin doses. Otherwise, they are at risk of hypoglycemia. So therefore, they need to have they need to monitor their blood glucose levels more frequently. For patients with GDM, we inform them to stop anti-diabetic medication, and we offer lifestyle advice. Breastfeeding is highly recommended. It is found to protect against maternal and fetal complications, and it also reduces the risk of the childhood obesity, type 1 and 2 diabetes. We need to pay extra attention to diabetic mothers because they are more prone to infection. Postnatally, we need to screen for type 2 diabetes mellitus. We can use the 75-gram oral glucose tolerance test. NICE, however, recommends fasting plasma glucose or HbA1c. However, OGTT is more sensitive to glucose intolerance compared to HbA1c. We noticed that patients with the GDM have a high risk of developing diabetes mellitus. It was found that metformin and lifestyle changes can help reduce that risk. When it comes to contraception, the choice depends on the patient and the presence of complications. Contraindications to contraception that contain estrogen include breastfeeding, smoking, hypertension, and other vascular complications. If estrogen is contraindicated, then alternatives include progestin-only pill, implantable progestin, or intrauterine contraceptive device. Now, going to the current guidelines, NICE recommends the use of thromboprophylaxis for pre-existing diabetes in case they have proteinuria of more than 5 grams per day. WHO makes a classification for diabetes as diabetes in pregnancy or gestational diabetes mellitus because their management differs. However, they give no recommendations on preconception care, antenatal care, or glycemic targets. American Diabetes Association recommends a target systolic blood pressure of 120 to 160 millimeters of mercury and a diastolic blood pressure of 80 to 105. They gave no recommendations on antenatal care or time or mode of delivery. The Canadian Diabetes Association recommends also giving calcium supplements for pre-existing diabetes as prophylaxis against preeclampsia. FIGO recommends less frequent monitoring of plasma glucose levels in the case of low resource setting. There are no recommendations on management of pre-existing diabetes. In conclusion, we noted that comparing our hospital guidelines to international guidelines has enabled us to notice the differences and similarities in the approach, and we found some areas that require improvement in our hospital, and that includes mentioning the teratogenic medications, recommendations on end organ assessment, and what type of medication to give as prophylaxis against preeclampsia. The increasing prevalence of GDM in Bahrain makes us realize the importance of educating the public regarding this medical condition and what precautions and implications that are associated with this condition. We also need to ensure that local practices are consistent with international guidelines. I'd like to thank my supervisor, Professor Mahmoud Sami Ismail, consultant OBGYN at KHOH, and the rest of my team, Dr. Stephanie Su and Dr. Gulmin Raza, for their continuous support. Thank you so much for having me.